Thank you very much, Mary, and welcome to all of you who have joined us. I'm going to try to speak for around about half an hour, perhaps 35 minutes on this topic, but I'm really looking forward to the questions and the discussion that will follow. I've chosen for the topic today, Palliative Care, Future Challenges for Ireland. And what I'm proposing to do is to go through a number of issues resulting from the research that we're carrying out here and elsewhere, and try to see what pointers that gives us to how we should be taking palliative care forward across the next few years. Before I go further, though, I'm in the privileged position that most of the work I do is in collaboration with others who do the heavy lifting. Many of you have been involved with collaborations with me, and I just wanted to acknowledge the inputs that you've all made, and of course then take credit for any of the results and the findings. So I'm going to start off saying a few things about the importance of moving from passion to evidence, even though I'm not trying to write off the importance of passion in this area in helping us drive forward the palliative care agenda. But I want to look at the ways in which the challenges for palliative care are going to be growing, and in my view, growing very rapidly. Then looking a little bit about what the evidence gives us in terms of pointers to where we should be going next, and in particular, looking at the whole problem of complexity and multimorbidity, because in my view, a lot of the challenges come from the fact that people are now developing multiple health conditions that mean they have much more difficult and much more complex needs than they had in the past, particularly now people who are coming towards the end of their lives who may have 5 or 6 different diagnosed diseases. It's also very important, though, for us to try and improve our understanding of what people actually want from services in the end-of-life period, but more generally, the services they want for their palliative care needs. And I want to look then a little bit about how this evidence that's available may well change the policy and practice in the delivery of palliative care. But at the end, I want to return to a theme that some of you will have heard me on before, and that is the importance of understanding how evidence from palliative care potentially should be making a big difference to the way that we look at the whole health and social care system. I've said before sometimes that the whole system is out of line with palliative care rather than palliative care being out of line with the whole system, because many of the issues we're dealing with, and the most important issues we're dealing with, I think cut across all parts of health and social care. Now, anyone who needs me to say who these two pictures are should be ashamed of themselves and should consider that maybe they're in the wrong profession. On the left, obviously, we have the founding giant of palliative care, and particularly palliative care in Ireland, Mary Aikenhead. And on the right, we have Cicely Saunders, the pioneer really of modern palliative care. Both of these people gave us a huge foundation for the development of palliative care services. They had extraordinary insight considering how little was available in terms of formal evidence, and they made a huge difference to the way in which we developed sensitive and appropriate services to deal with people's needs, and particularly their needs for symptom control and needs near the end of life. However, we are now moving to having very much better evidence, and what I'm wanting us to try and think about is how we take the passion, the interest that these people gave us, but also blend that with the emerging evidence around what works and what people want and how we should be taking the system forward. So what are the growing challenges? Well, whereas we know that palliative care is much more than end-of-life care, we also know that the number of people approaching the end of life is a reasonable indicator for the ways in which palliative care needs will grow. And the number of deaths annually in Ireland is likely to rise by about a half in the next 25 years. That is an extraordinary challenge because for years we've been actually seeing the numbers of annual deaths falling as life expectancy increased. But as you will all understand, eventually people have to die, and so the numbers of deaths are likely to rise very dramatically. Alongside this, we have increasing evidence that palliative care needs are only partly met at the moment. And taking that into account, I think it's a good estimate that palliative care needs will double by 2046. Some years ago, I was speaking to the chief executives of the hospices in Ireland, and I said then they should look out of the window, see what was there, and at that point say, well, we'll need about double that. Of course, the double that won't be exactly doubling all the facilities and all the services because they will change and the configurations will change, but double is about right. I was amusing myself the other day because after many years of careful research, and particularly work that's been led recently by Peter May and Karen Ryan and others, and the work that was done in England looking at similar things, I went from thinking it was about double to thinking it was almost exactly double. It's a bit like Ford Prefect, if anyone doesn't know the background there. He was in the Hitchhiker's Guide to the Galaxy. And after many years of study, he moved from saying that the Earth was harmless to saying it was mostly harmless. Here again, I'm saying we thought it was about double. Now we're pretty sure it is almost exactly double the needs that we'll have in the future. So what evidence does economics and what does the other related evidence tell us? Well, we know a lot about how to manage single diseases. We know a lot about what works in the management of single diseases. And we know quite a lot about what are the most cost-effective ways to manage symptoms that are common in people with life-limiting disease. We've got some evidence around the effects of palliative care interventions on patterns of care, and I'm going to be emphasizing this quite a bit. And we have a certain amount of evidence about what patients want and what is valued by them and what is valued by carers. So we do know quite a lot of things that are quite useful for thinking about the future development and configuration of palliative care. But at the same time, we have much more evidence around single diseases than we do about people with multiple health conditions. If you look at the guidelines that are available within health services generally, they tend, in most cases, to be focused on single diseases or simple combinations of disease rather than the multimorbidity that's much more common. And multimorbidity is the norm. It's one of the things that is, I think, increasingly now understood is that very few people attend health services of any sort with only one thing wrong with them. A reasonable estimate, I think, is around 60% of all primary care attendances are for people where the problem is related to more than one diagnosed disease. So the normal attender at a primary care facility is someone who has multiple needs. What we also know is that once you move into people having multimorbidity, the choices become much more complex because we have competing objectives and we have trade-offs between these objectives. And I think we're all aware, even just looking at our own families and people within our own families, of how this problem is really very serious. For example, I'm very aware of a circumstance where someone was on beta blockers because of trying to manage their atrial fibrillation, but that was making them dysfunctional and likely to fall. And given those sort of trade-offs, is it better to manage one part of the disease problem or manage another? And we are increasingly in a need for expertise around managing complex needs as opposed to managing relatively simple needs. And we are having to manage these complex needs with mixtures of interventions that are then obviously very complex to evaluate. I'm raising these questions because I think we've got to understand what sorts of evidence we really can hope to have because the evidence is unlikely to be like that you get on the usefulness or otherwise of a single drug or a single piece of equipment, where you're simply saying, does this work or does this not work? Because we're looking at the need for evidence around how can we help meet complex needs with complex combinations of intervention. And the likelihood is that the nature of this evidence will be much more flaky, will be much more uncertain, but nevertheless is very important and is needed if we're going to make better choices. Alongside this, though, we have frameworks of measurement and evaluation that have grown up, which overall have had the tendency not to measure complicated things. And indeed, if you look at most clinical trials, they exclude large numbers of people because they have complex needs. And yet those are, in the end, the targets for the interventions that are under evaluation. So I'm not going to say an awful lot about the problems of measurement, but I think we have to be very aware of these problems. And again, these will affect the nature of the evidence we can generate and the types of advice we can give in terms of the future development of services. Measurement tools, though, I think have some very important characteristics which are, in my view, quite harmful. One of them is that it treats time as if it is a simple notion. You look at time and say, if you've got 2 months, that is twice as much as 1 month. What we're increasingly understanding is that people's experience of a complex set of needs and a complex set of interventions is much more likely to be thought of in terms of the whole trajectory of care rather than as months or days or hours that would otherwise be evaluated. So, for example, someone won't be saying, you know, I had 20 days when I was pain-free, and that was twice as good as 10 days that were pain-free. They would be thinking more in terms of my pain was appropriately managed over the trajectory and was managed in the context of my need to function in various ways and have various capacities during that time. So people will be looking at the whole story much more than looking at single discrete periods of time. And I think this is very important because in the end-of-life period in particular, but for all people with life-limiting disease, time is very often quite short, and people's experiences within that time can be very intense. So simply adding up units of time and saying, how well did we do, is often missing the point that we're interested in trying to get a much more profound understanding of what someone's experience looks like. And there are some measurement tools that are under development of trying to get around some of these difficulties, but we're still stuck with a fairly conventional view that you're looking at just adding up things that are not in people's heads added up at all. And I've spoken and written a lot about this in other contexts, but I think it's important to understand again, the nature of the evidence we have is always going to be limited by the quality of the tools that we have to do the measurement. Now, I want to say a little bit about what we know about what people want. And we do have an emerging body of evidence around what people want. And the first thing that I think is quite reassuring is that increasingly we now understand that people with life-limiting conditions and palliative care needs are very focused on getting good clinical care. There was a trend, perhaps more 15, 20 years ago than now, to try to demedicalize the idea of palliative care and try to see a much more social model. But what became clear from the evidence was people are really interested in there being good quality, effective, available, accessible clinical care. And they're not very interested in trading this off with other features. So unless you can get effective, high quality clinical care into the system, people are not very interested in other things you are doing. As someone once put it to me, I'm not really interested in talking about knitting and other pastimes of that sort unless I can be sure that my clinical needs are being appropriately met. Alongside this, we are increasingly understanding that the processes of accessing care are of huge importance to people. We all know that in the period in which people access palliative care, there are a lot of other stresses around, a lot of stresses upon people. There are a lot of difficulties families are having to face together. And under these circumstances, the last thing they want is to feel there are barriers to accessing care. And I think this is critically important because very often people are much more focused on, can we get people the right things? I'm much more focused on, can we get people access in the right ways? Can we make sure that accessing the services that people need is very easy to do and it isn't surrounded by constraints and difficulties and complexities? And I think we need to bear this in mind, for example, around the problem of what some people would see as over-provision. Because if you're giving people very easy access to care, sometimes it will appear to be underused. That's to say, you know, if someone goes to, say, a palliative day care program and they decide on that day that they don't need A, B, and C, and A, B, and C is available because that's part of the package, then it may appear that that is a little bit of a waste. And obviously we can, to some extent, overbook and manage around those things, but there will always be some apparent waste if that happens. My point is that that apparent waste may not be waste at all, because what people are looking for is the insurance that there is available to them things that they might need, even if on a particular day they don't. And it's quite a difficult mindset to change, because those of us who work around health and social care are so obsessed with the need to try and get absolutely everything we can from the resources that are available. But the reality is that one of the things that people need is a feeling of easy access, even if on a particular day they don't choose to access that service. And so we really need, I think, to be interested in process of access and how we manage the support that people need in gaining access to the appropriate care in the appropriate places at the appropriate times. And we also need to be able to manage their changing needs over the trajectory of the disease. And that is often difficult as well, because we really like the notion that somehow we can plan in advance. And advanced care planning is really important, but advanced care planning has to be planning rather than plan. It needs to be a continuous process that we recognize as being more than a single decision, and is really a set of decisions. I because I'm a kind person, I won't actually sing this for you, although that might make a more lasting impression. But the point that is being made in this song, Oliver and Young wrote very many years ago, 80 years plus ago, that it's not what you do, it's the way that you do it. I think we sometimes should be singing this to ourselves in the morning when we're setting out to plan what we do, because it helps us get away from the notion that what we do is the most important, towards the notion that the way we do it may be even more important. And you note that last line, that's what gets results. And I think we need, again, to recognize that people's experience of accessing care can be absolutely critical in the results being a satisfied person or satisfied family, a family that feels they have been appropriately supported in getting their access to care. I think we also need to look at the evidence that's beginning to show us that there are differences in what different stakeholders are looking for in palliative care. And I'm increasingly concerned about proxy decision-making, given the emerging evidence that what caregivers are looking for and what service users directly are looking for differ in important ways. Not completely, there are many overlapping things that they're looking for, but as a simple version of this, caregivers are more focused on disease and patients are more focused on managing the quality of life. And we see this quite frequently in the differences between what people would think were appropriate decisions for their relatives and what people think of as appropriate decisions for themselves. So we really need to be aware, I think, that there are different views and we have to manage around these differences and the fact that people will therefore be asking for different things from the delivery of palliative care. And I come back once again to looking at what we really mean by outcomes, because people clearly value the processes of care, the access, the availability, the style in which things are done. And in some senses, the processes are the outcomes. And looking narrowly at measured outcomes that ignore how you get there is in important ways missing the point. So we really need to understand that people are interested in the journey. They're not just interested in the destination. And I think it's particularly important where you've got changing needs over time, where the quality of the journey will be reflecting the ability to respond appropriately to changing needs as they occur. But I want to come on to what I think is one of the most important themes in what I'm discussing today, and that is the importance of us supporting better decision making. I've already referred a little bit to advanced care planning, and within this, I think we also need to look at what mechanisms we can put in place that can help people to make better choices, to ensure that people are supported to make the difficult decisions around what will be most useful for them to have. Whereas palliative care is much more than about better decision making, a core part of good palliative care is supporting people to make better choices. And we've been involved in a number of studies around this, and the evidence is really very clear that if you support people to make better decisions, you can improve their outcomes. That's outcomes in terms of the experiences that they have. You can significantly reduce service use and you can lower cost. And this is particularly the case where the person has complex needs. And increasingly, as I was saying, we are dealing with people who have complex needs. And I think we really need to bear in mind that people with complex needs may accidentally get a lot of care that will not be useful to them because it doesn't take into account adequately the context in which they are being treated. And this is, I think, an important part of how in the future we need much better integration of palliative care into general care in order that we can pick up people who have got these complex needs and who are at risk of futile and inappropriate care. We know that people with cancers are most likely to benefit from better support for decision making. And we know also that people with some cancers have been shown to live longer if they get better support to make better decisions. So again, it gets us away from this idea that there is an obvious trade-off between a palliative care agenda and a curative care agenda. There are many cases in which they probably make it makes no difference which route you go down in terms of life expectancy, and there are some cases clearly where better choices will lead to people living longer as a result of having less inappropriate treatment. Another important point about supporting decision making is that the earlier you start to support decision making, the bigger the difference it makes. This is not in any way a surprising finding, because the longer you have for your better decisions to take effect, the more likely you are to have improved outcomes and improved experiences. And we've got a nice example of this in some collaborations we did with Owen Tiernan in St. Vincent's, where people were flagged in the emergency department, people who were frequent users of emergency department and were known to the palliative care system. When they were flagged and an intervention was made there, they had a lower cost, better experience. So the outcomes were improved and the cost fell. And this was largely as a result of removing both interventions and investigations that were not useful given the overall circumstance, and where they caused distress and cost but didn't improve the experience of those receiving the care. I'm not advocating that we should be expecting a large part of the future demands for palliative care to be funded simply from using resources more efficiently, but it is a contributory source of resources, because if we can reduce the amount of inappropriate care, we can obviously redirect some of those resources towards more appropriate care. And we have clear evidence that you can reduce inappropriate ways, inappropriate care and futile care by having better decision support. And we need to look at the best ways of providing that better decision making that will help avoid some of this futile care. So what do we have to do? Well, first of all, we need to understand that we need to double capacity approximately. And I think that's not a bad thing just to bear in mind all the time. Whatever we do, we need to do on average twice as much of that. But people get very concerned about the exact models of care and how best to do it. And one of the things I have found from years of working with palliative care providers across Ireland and in other countries is that there are many different models, and very often they work in pretty similar ways. I mean, I've been always interested in, you can have more voluntary and more statutory services, ones with a stronger physical base and ones that are more outreach. And very often the experiences are actually surprisingly similar. So I think we should be more concerned about the overall need to improve the capacity and allow the evolution of different models of care, and indeed maybe models of care that are managed in different ways that reflect the different local circumstance. If there is a long tradition of voluntary organizations providing palliative care, they may well be able to take a very useful part in the future development, even though in places where it has been much more patchy in the past, we might want a more statutory approach. So I think we've got to be quite flexible about this, but every time you think about the developments, you need to be thinking about it needs to be about double. But I think what we do now understand is we really need to ensure that however we do the organization of palliative care, it is much more integrated into the health system. Even if organizationally distinct, it needs to be much more integrated. And this is because we now know how important it is to get support for decision making and better understanding and better management of people's palliative care needs relatively early in the trajectory, not coming at the end as a sort of throwing in the towel we hand over to the palliative care system. And I think there are different ways in which we can be more integrated, and I'm not really very concerned about what models of integration are there, but we do need to increase the extent to which palliative care is an integral part of the overall system and not something that happens at a specific time or in a specific place. And we need to be much better placed for managing early interventions than we are at the moment. We need to improve the support we give for decision making, particularly for people with complex needs. And we've got some examples of this. As I said, we've got examples in the emergency department. We've got examples of people being approached when they're coming into an acute hospital admission, but we also need to find ways of being more integrated into the primary care systems, because after all, that's where people have an awful lot of their health encounters and where their palliative care needs may need to be identified much more clearly. But we need to be organized to meet the whole trajectory of needs that change over time. So again, we need to have systems of evaluation and measurement that are much more dynamic and which continue to evaluate people's needs as they change. And this obviously means we need to plan for staffing and skills and skill mix. And I think it's very important for us to recognize that the evidence suggests that multi-professional teams in general have a better experience, have a better outcome than if you try to organize services around single professions. So we need to be planning for a multi-professional team, and we need it to be organized in ways that are much more integrated with the delivery of primary care, hospital care, and long-term care. We need while building on voluntary efforts, I think we've really got to bite the bullet and say, actually, core services need to have core funding. I know that there's been extraordinary success in raising extraordinary amounts of money to put in place voluntary-based palliative care services, but in the end of the day, you will always have a patchy delivery if it is only dependent on voluntary effort. And I think this is part of our need to argue for mainstreaming the delivery of palliative care, because it is in that sense ordinary. It isn't a different thing that has a different philosophy. It does have some different philosophy, but it is a core part of the delivery of care and should be much more integrated. And quite frankly, in the next 10 years, we really should see a situation where voluntary effort gives you the frills and the little nice extra bits in the system, but should not be the core source of funding for these services. It will not be possible to provide for all the unmet needs that are there and the growing needs that are coming simply by saying, let's do more fundraising. I'm not against fundraising. I'm not against voluntary effort. I'm just saying we are relying far too much on it, and it really needs to be moving into the mainstream for financing, because it is mainstream. And as we know, it might, in effect, reduce some of the costs that we're getting across the acute and primary care systems if we can get better decision-making into the system. So it may be that mainstreaming the financing is also in some ways leading to better use of the core resources that we use. I come again to access and processes because really, if you look at complaints within the health and social care systems, they're almost always largely around unsatisfactory processes and people being unable to make the access and availability work, much more than they are about the specifics of the care being wrong. And I think we need to come back to how do we ensure processes are appropriate and are not causing additional stress. We need to move towards better measurement systems that are more sensitive and holistic, and there's a lot of work in this area, but we really need both to develop better measurement, but also to develop better understanding of how we use the results of this measurement, because it won't be simply like the results of controlled clinical trials of a particular vaccine or a particular drug. And we need to continue, I think, to listen better to what people really want, because we are increasingly understanding that what we would guess people want may not be what they really want. I just want to say finally a couple of things about palliative care in its relationship with the health and social care system. First of all, I would see palliative care as being like the canary in the mine. It provides an understanding of wider issues by the fact that we are providing services in the context of people with very profound needs and very difficult circumstance. So it's not that we are different, it's just that we appear to be different because it's a more extreme version. And I increasingly think that some of the insights we've got from palliative care research have very profound implications for the way that health and social care in general are delivered, largely around how we manage complex needs and around how we manage access and availability in the context of people who have a difficult time to navigate their way through the system. And we have to remember that the health and social care system is mainly around supporting people with multimorbidity and complex needs, but is still structured very much around the unexpected event that happens when somebody gets one thing wrong with them. And as I said at the start, maybe other services are out of line with palliative care rather than palliative care being out of line with the rest of the health and social care system. And if you have been listening, thanks for your attention.
So thank you very much, Charles, and very informative presentation. We've had a number of questions come in, so if anybody would like to submit another question, please do so on the Q&A chat box. I suppose one of the questions that is quite interesting is, how can we move the money to follow the patient, regardless of the place where palliative care is delivered? So I wonder, Charles, do you have any thoughts on that?
Well, this is obviously an issue around the whole health and social care system, as well as how it applies in palliative care, because we are still sort of 30 years after the Irish health system has decided it wanted to move towards money follows the patient. We still have money follows the building. And so, you know, we're a very long way from any part of the health and social care system really working on that basis, although perhaps the gradual expansion into pre-primary care will begin to move us in that direction a bit more if it's done on a capitation basis. But I think it's really around detaching the funding model from being to fund places and activity to fund the needs of people. And I think we're seeing little openings here around, for example, some long-term care, where we're beginning to move towards what's effectively budgeting around an individual's needs. And we need certainly to have ways that we use activity that is appropriate activity as a basis for funding in place of simply funding organizations and institutions. But I think it's unlikely we're going to get a real move in the palliative care area without getting a significant move in the acute hospital system and to some extent in the primary care system. So I think to some extent we've got to live with a dysfunctional funding model if it's applying across the board, until we can begin to prise open, I think, a little bit that agenda of moving towards money follows the patient across the whole health and social care environment.
Okay.
That may be unhelpful, but it's the only thing I can say.
No, thanks, Charles, for that. And I suppose, you know, quite a linked question as well that's been submitted is, how can we address the inequity in access to palliative care services?
I think one of the first things is actually to understand it, because the inequity has never been in the past very well measured, because the palliative care provision was on the fringes of the data systems that were there. I think we made quite a lot of progress towards having better palliative care data across the country than we had in the past, but nevertheless, some of the inequity was invisible, because simply if there wasn't a service there and there wasn't any reporting and there wasn't a geographically based information system, you just didn't see it. But I think we are seeing some, I think, quite good developments, because we're seeing a number of new palliative care organizations growing up in places that previously were underprovided or had very limited provision. Some of this inpatient facilities and facility-based outreach services have been developing in other places. And the reality is that most of these developments do have to have public funding, because raising a lot of money locally to innovate and develop new approaches of this sort is just going to be too difficult. So I think, you know, to some extent there has to be the lever of public funding to try and even out that inequity. But at the same time, I think we do need to try and help ensure that the existing voluntary efforts move increasingly into being publicly funded in places where they're good, because the last thing we want is to have the inequity reduced, but the overall standard reduced at the same time. So I think we've got to be careful on that. But I think a lot of it is simply having the will to provide the not huge amounts of public money needed to put in place services in the underprovided areas. And I said we made some good starts on that, and there have been some very good models of additional provision. But there are still some areas that are significantly under-resourced, and under-resourced both in financial terms, but also in terms of skills and capacities to deliver good services.
And thanks, Charles, for that. And I suppose that also brings in, there's a number of questions about the role of the informal caregiver, how the quality of that can be maintained. And another question that's come in as well around state funding for voluntary services, and where they are part funded by state and part funded by fundraising. You know, and it has been working very successfully in some areas, like in the UK with Marie Curie. So just to maybe talk a little bit about that, about the voluntary services, if you've any thoughts on that, Charles.
There are two slightly separate issues here. One is about informal carers and informal care, and the other about how we harness the sort of voluntary effort most effectively. I'll just say a few things about informal carers first, because I think there's some really interesting evidence around these people's roles that can give us a very important pointer to how we should be making progress. Obviously, informal care is a huge part of the delivery of support, particularly in the end-of-life period. And we know from studies that if you try and value informal care in terms of something like minimum wage, you would find that about half the cost of care for people in the last period of their life is coming from informal carers. So that's people taking time off to look after relatives, it's people doing unpaid work and so on. But what's really interesting is that the more you support informal care by providing in parallel some formal care interventions, the more the informal carers can do what they can do best. We see that informal carers tend to have something quite close to being a fixed time budget. They may be able to provide, say, 2 or 3 hours of care a day for their relative. If the formal care system helps with the more basic care needs that the individuals have, then the informal carers move into this other space of providing personal support and activities and interest and interventions of that sort, which are hugely important and which are very difficult for the formal care system to do. So rather than seeing them as being different things, what we see is informal care does, if you like, the wrong things if you under-support it, and does the right things if you support it well. And that seems to be fairly well documented in a number of countries. So it's very clearly documented here, but it's documented in other places. I think this issue around voluntary effort and the huge role that the voluntary system has played in palliative care, I think what I would like to see is a situation in which luck is taken out of the equation a bit, that if you happen to be lucky and you live in an area where there's been very effective fundraising, you get a good service, and if you don't happen to live in that area, you get a bad one. Equally, it is in some senses unfair that people work incredibly hard to raise money only to find their public funding goes down by the same amount. So in those sort of ways, I think we need, in some sense, just to move our mindset to this is predominantly a system that is funded from normal health and social care funding, where you can give some local additions and some local excellence from voluntary effort and some innovations, and do all the things that the voluntary sector does better, like having new ideas and trying something out, but moving away from the notion that ultimately, if you happen to be lucky and live in an area of good fundraising, you get a much better service than if you're unlucky. I mean, in general, Sláinte care is all about trying to remove those kinds of differences. I know they're difficult to remove, but part of it's in our head, because in the end of the day, we're not talking about very much money. The additional needs for palliative care support, if it were to be done through public sources, are not large compared to the increased monies that we're spending now on managing the COVID-19 crisis. We get an idea that because there are 6 noughts on the end, that it's a lot of money, but it's actually not a lot of money relative to the overall health and social care agenda.
And I suppose that also links to another question that's come in and link into that, I suppose, how to get funding into palliative care. From your experience, Charles, what are the most useful bits of health economic evidence when advocating for the investment in palliative care?
It's a slightly depressing starting point, but of course, where palliative care can be cost neutral or can save money, it obviously has an easier case to make than where it requires additional resources. And I think there are lots of ways in which we can demonstrate that we can improve the experience at no cost, or at, in some cases, in the context of a saving. So I think that evidence can be very powerful. And if you look at what's happening in the United States at the moment, palliative care has had a relatively good run because they've been able to demonstrate that they can reduce some of the what's effectively just wasteful use of health resources in inappropriate care that has a curative intent but actually is pointless because it won't achieve its objectives. So there are, I think, so we can argue some of that. I think, though, that there are some other bits of evidence that are quite important, again, in changing mindsets and changing some of the discourse around funding of services. For example, I talked a little bit about availability being an objective that people have, even if it's not use. And people will start off saying, well, you know, we had the capacity to see 20 patients and only 12 wanted the service that day. But those other 8 were people who benefited from its availability. We don't say, I was a terrible waste having my car insurance today because I didn't have a crash. You know, you would be going the other way of saying, well, wasn't I glad that I had insurance in case I had a crash? And I think there's a little bit of a mindset change needed there, that things that appear to be a little extravagant, like very easy access at weekends, for example, something like that looks a little extravagant because it appears to be a bit underused, is nevertheless fulfilling a very important other purpose. And again, I think we can begin to demonstrate that people really value some of these access issues much more than they value, did they get it exactly right or did they get it largely right? They're very interested in, did I get it when I thought I needed it? And you know, the Monday to Friday 9 to 5 mentality in terms of when it's efficient to provide services is missing the point that people really need to feel availability is there at a time when they feel they need that availability, even if they're wrong. And of course, quite a lot of the time they will be wrong. And
yeah, and I think, Charles, it links into what you were saying, is to provide access in the right ways and in supporting people with the decision making. And I suppose there has been a number of questions around that, around caregivers and understanding what the patients want and how to have that difficult conversation if you're the caregiver. And in relation to that then as well, with advanced care planning and the amount of research that's gone into that area, and how can we, you know, put that research into evidence? I wonder, can you talk, I know they're broad topics, but something around that, Charles?
Yes, I mean, I think the advanced care planning agenda has been hugely important, and I'm very much a supporter of the research that's going on in that area. It did, of course, start off in some ways with one hand tied behind its back, because the notion was somehow you put in place a plan and that then allows you to do the right thing when the time comes. And it was slightly slow to come into the area of changing needs and changing plans that are needed. So I mean, there's a little bit of a risk. I know it's very easy for us to say at a time when we're well, this is what I would like when I was less well, but we do need to accommodate people's changing views. And I mean, there's a nice example of this. There's an increasing body of evidence now around preferred place of death. But the most interesting thing about this now is not that people's preferred place of death is generally in their own home, which it is, but that it is very frequently changed in the light of people's experience of their care needs as they approach the end of their life. So that we need to put in place mechanisms that allow people to change their mind and to evolve their understanding of their needs as time goes on. So I think that's one of the challenges. And again, if you look at the various tools that have been developed over the years for trying to do needs assessments, very often these are absolutely fine, but 6 weeks later they're no longer applicable because someone's needs change. I think all of us who have personal experience of looking after relatives who are in the last period of their life will know every time you think you've got it right, the problem changes. And you get, it's if it's not one damn thing, it's another. Because as soon as you've accommodated one lot of needs, you find that the needs have evolved and changed. So I think there's a particular challenge around this evolving need. But just coming back to what people are looking for, I think the reason why I'm very focused on helping people to make choices is that what we know is that people's objectives are hugely varied. And trying to put in place a mechanism of choice as opposed to a supporting system for choice, where we're not actually saying these are the 5 choices you have, tell me which one you want and we'll go with it. We're saying we need to have a bit of time. And one of the things that, again, I have many times told the story of the Chinese doctor I met who claimed to his managers he was practicing traditional medicine because they let him spend 40 minutes with each patient when he was doing that. When he was doing Western medicine, he was only allowed a quarter of an hour. And I thought it illustrated very well that sometimes what we need is expensive, highly skilled people with time. And what we've shown from the evidence around the effects of better decision support is that actually that extravagant use of time is really good value because it saves so much inappropriate use of resources at other stages. So again, I think we've got to be willing to say, well, actually a lot of people have needs that will be evolving and changing, and we need decision support mechanisms that are evolving and changing with them. And to some extent, this will be, and perhaps completely, be self-financing because what it avoids in terms of inappropriate care more than pays for the mechanisms of decision support. But I think, I would be supportive of us all having advanced care directives of various sorts, but also keeping them available and keeping them ready for change and having mechanisms for change in there, recognizing that people's views might change very late on in their life as well as they come to recognize the challenges of caring for them as they get more and more dependent and have more and more multiple and complex needs.
And I suppose just in relation to that, Charles, as you mentioned, that valuing of the expertise and experience to allow you to make the decisions that will then go on to avoid inappropriate care is so important. And those kind of studies are very important in the area of palliative care. We've had another question here. It's quite a detailed health economics question, so I don't know whether you want to take it offline with the person, but they're asking about the Grossman model of health production. And they're wondering, is it not well placed to analyze complex and multi-morbidity situations? And Grossman model seems to imply that a return to full health is possible, which may not be feasible in complex cases.
Well, I think I would largely take that offline, but I think there is a lot of usefulness in looking at the value of interventions in terms of changing people's capacity to operate effectively. And this includes, for example, supporting informal carers in ways that allow them to fulfill their other roles and responsibilities as well. So the use of other tools and measurements that say, well, actually, we're interested in the person's capacity to contribute more widely, and the human capital that they have can be used better is quite important. In the specific case of people who have life-limiting illness, and particularly those who are quite near the end of their life, the objectives are very much in terms of trying to optimize that experience for those people and optimize the experience with their relatives. And what we do know, for example, is to an extent you can buy a lower grieving experience, a better grieving experience by having better support for informal carers. And grieving experiences, if they are less severe, are going to have less disruptive effect on people's economic activity and their ability to contribute. So, we know there are some things you can do that will actually improve the overall functioning of the care system by allowing people to be supported in ways that make them better able to live with the changes that happen and manage the bereavement that follows. So, I mean, I think we can get some feedback into more conventional economic ways of thinking about this, but the specific needs of an individual who has a life-limiting condition are normally in the context of them being unlikely to have even informal, unpaid work that is of significant value, rather than being people who are likely to participate more in the labour force as a result of improved care.
Okay, and we could maybe get back to that specific, more health economics focused part of the question as well, Charles. I know the time now, I wonder, I suppose it's good because we are talking from the palliative care research perspective. Just one more quick question, and then we'll finish up, is around, the area of palliative care, and to come up with a suitable research design to build evidence-based palliative care in its complexity. And I suppose the person who's asking this question is, have you thought about a matrix design to help address complexity? Is there still a role for studies where the N equals 1? I suppose it's the whole area of palliative care research. So I don't know whether you want to.
For a long time, I've been very critical of the simple-minded notions around hierarchy of evidence. And, nowadays we're not allowed to be rude about public health doctors because they are now the core workers in our world. But for a long time, public health doctors were being taught, the sort of grade 1 evidence is this, the grade 2 evidence is that, the grade 3 is for, and so on. And there was somehow almost entirely irrelevant evidence that came from a randomized controlled trial was superior to very useful evidence that was a bit more flaky because it had to carry out the research in real world situations. We've moved an awful long way from the time when the 5% fascists with their randomized trials were the only people who had any sort of moral standing in the research world, towards a much more pluralistic view. I think there are two kinds of needs, though. One is to design studies that start off from the basis of saying, what is the best evidence that I can generate in the constrained circumstances that I live in? And the constraints may be that there's a limitation on what you can withhold from people, and therefore you can't have normal control groups in a study. Excuse me. So that there's, to some extent, we have to say, we're not abandoning our desire to have the best possible design. We're just saying we want the best possible design, not the best conceivable design, because the best possible one will have some difficulties. For example, it may use some non-experimental design that tries to compensate for the loss of the quality of the evidence that would come from that. So I think, our starting point is fitness for purpose. the second point that I'd make, which is looking at it from the other way, we have a very naive approach, I think, to the way in which policy and practice uses evidence. For example, historically, people would say, unless it meets particular standards, we would say it doesn't exist at all. Because we would say, yes, there was a study, it did not show a significant effect. What that meant often was that only 18 times out of 20 rather than 19 times out of 20 would that have been true. And, you know, when I'm buying a banana, I can be quite happy with relatively weak evidence that it's the perfect banana for me, because I still would rather have, you know, a banana that's pretty well what I want rather than a banana that I know is absolutely not what I want. You know, so the quality of the evidence you need may not be at this sort of 19 out of 20, which traditionally was seen as evidence. And indeed, people discarded huge amounts of evidence that came from either non-experimental designs that were considered to be problematic, or failure to meet particular preordained standards in terms of statistical evidence. And, you know, basically, we need, I think, as users of evidence, to say the best evidence we're ever going to get on this kind of thing is likely to have these kinds of problems, but it's an awful lot better than no evidence. And so I think we've got an agenda to try and inform policy and practice to say, well, actually, we've got to live with standards of evidence that we wouldn't accept if it was in brain surgery. But actually, we don't care because we're not doing brain surgery. You know, and the other thing that I think is important, if you go back to just the example of what patients want, in many ways, we are now understanding that patients want what they know about. And, you know, they can be equally satisfied with very different experiences if they are provided in a benign and helpful and pleasant way. And there was a nice piece of evidence that I've always focused on, and that is that people are very unforgiving about bad process, but they're quite forgiving about not getting it quite right. And so you say, you know, I went to see someone, I asked what was the best thing to do, and they didn't know, and they said they would find out as quickly as possible, and they did their best. And even then, they didn't get it quite right, but they were really helpful. Tends to dominate the, I'll tell you on Monday, go away, it's a weekend coming up model of support, even if on Monday they got precisely the right answer. So I think, you know, some of the evidence suggests that people accept that when you've got complex needs, there aren't going to be magic bullet solutions that are simple and linear and easy to describe, easy to implement. Very often they'll say, we'll try this. If it doesn't quite work out, we'll try something slightly different, and we'll do our best. We'll use whatever evidence we can gather in your circumstance, because you are always going to have some features that are different from the rest of the population. And therefore, we can't be absolutely certain at any given time that this is the best magic bullet for you, and this is the only way that will work. So I think we've got a maturity we need to develop in the way we design studies that is always looking for the best possible design, but recognizing that the best possible design may be really not as reliable as some others, but it's the only feasible one to ask the right question. And then we've got to be more mature in our use of evidence, of saying, well, even slightly flaky evidence may be an awful lot better than none. And let's not be as prejudiced as we are, as say it's not brain surgery, and the only difference is it's more important than brain surgery.